the Gifford Provider Podcast, the podcast of Gifford Healthcare based in Randolph, Vermont. I'm Scott Fleischman. Gifford is a nonprofit critical access hospital and federally qualified health center with a total of 9 locations throughout central Vermont and the Upper Valley. Gifford's main campus in Randolph is home to a 24-hour emergency department, inpatient and rehabilitation units, a renowned birthing center, an accredited cancer program, advanced diagnostic imaging, surgery, and much more. Go to giffordhealthcare.org to find all the services we provide, the latest news, blogs, and healthcare information. With November being Diabetes Awareness Month, we wanted to have on Katie John. Katie is a family nurse practitioner, board certified. She works in Gifford's diabetes clinic. She joined Gifford in 2020. Katie, thanks for joining us. How are you?
Good. Thanks for having me, Scott.
Before we get into our conversation, if you're watching us on YouTube, don't forget to click the subscribe button, like this video, tap the notification bell. That way you're always going to know when we have new content for you to watch. On our YouTube page, we have other podcasts, important information from our medical team, and testimonials from both patients and Gifford staff. You can listen to the Gifford Provider Podcast as well. We're on Spotify, Google, Amazon, and Apple Podcasts. Do a search for the Gifford Provider Podcast. Once you find it, follow the podcast, give us a review, and share it with your friends. Those comments are really important. Your feedback helps this podcast grow to a larger audience. So once again, Katie John, thanks for joining us. And, you've been in Gifford here now a couple of years, really adding so much to our diabetes clinic. Tell us how you first got involved with diabetes care.
Yeah, I was completing my bachelor's degree in nursing. I initially got an associate's degree, and through that baccalaureate program, I had to do some type of clinical experience, right? And I happened to find an internship with Dartmouth Hitchcock in their diabetes education department, and an educator, Rita Kate, who is now retired, but she was a wonderful mentor for me many years ago. And I just fell in love with the whole specialty of diabetes education and managing diabetes. And I learned so much, and it just kind of ignited this fire passion in me to continue to learn more. And so when I went on for my master's degree, I pretty much focused on diabetes throughout my program and did my master's thesis project on diabetes. And my ultimate plan was to work in the field. But when I graduated, I got a job in primary care and did that for 5 years, and then went to work in endocrinology. So it's been a passion for a while. I just find it so fascinating. There's such a blend between just that human factor because it affects every aspect of our lives, right? And then there's math and technology, and it's a lot. And even all my patients throughout the day, they all have the same diagnosis, but they're all very different and individual. And I don't get sick of it. So that's the long and short of it, basically.
So before that, did you have any prior exposure to diabetes? Anyone in your family, any knowledge of it at all?
No, it wasn't any personal experience, really. I mean, I did have some, sort of more extended family with diabetes, but nothing really, a lot of people will get in because they've had, a close family member or whatnot, but no, that's not been my case. But I had been working a lot in inpatient cardiology units and things like that. And a lot of patients had the comorbidity of diabetes as well as cardiovascular disease. And so it certainly was something I was seeing a lot. So, but yeah, not any either my own personal or family.
Well, that's very interesting because, a lot of the times you talk to people who get into a certain thing just because they've had that background or they've had that history of it.
Yeah.
So how did you end up at Gifford?
So I'd been working in another facility in Central Vermont, and I was sort of ready for a change. I knew another provider that worked here at Gifford, another APRN, a nurse practitioner, and she was happy here. And then also I knew Jennifer Stratton, my now colleague, through just sort of, there's not a lot of diabetes educators here in Vermont, and so we kind of know each other. And I got to talk with her a little bit more and just hear how from both of them that they felt that Gifford was really flexible as far as the work-life balance. And it sounded like they were feeling really good about the care that they were providing. And so I said, okay, well, why don't I put out my resume and apply? And I've certainly found that to be true, that I feel like the administration here is very supportive about treating our patients well and making sure that they're getting what they need. And so that's important to me. And I feel supported as a provider, making sure that I can try to do right by my patients.
You talked about not having a lot of diabetes educators in Vermont. How important is it to have that education, have a diabetes clinic in rural areas, especially?
I think it's really important. And so, of course, people have to travel a lot in Vermont for healthcare, and that can be a barrier. And so if we have a clinic in in a rural community, that hopefully will cut down some of that barrier. Oftentimes patients feel more comfortable getting care in their own community versus having to travel to a big medical center. And then you're right. So there isn't a lot of us, I guess, to answer your question, that there's not a lot of us diabetes educators here in Vermont. We're sort of spread out. So we cover a lot of territory. But there's kind of concentration, at UVM, at the big med center and things like that, and in Rutland. And then the rest of us are kind of spread out. But I think it's important. And from what I hear from our patients, they feel good about being able to not travel far, and they're able to get good quality supportive healthcare.
You mentioned Jennifer Stratton a little bit ago. Talk to us about the diabetes team here at Gifford and the services that this clinic provides.
So Jennifer is an RD. She's a dietitian and a certified diabetes educator. And she and I work very closely together. We work closely with, sometimes one patient will follow up with Jennifer one visit and then with myself, and vice versa. So we try to support people with alternate visits sometimes. So she and I are the primary providers. And then we have a medical assistant, Caitlin, who's also here. And we're actively looking for a medical secretary to come and help us welcome our patients. So if anybody knows of somebody who wants to come work with us, it's a great job. Anyway, so that's our team. And we try to kind of soup to nuts provide of course, the education at first diagnosis, dietary information, if someone were to need to inject insulin, how to do that, how to monitor their blood sugars, all types of things. And then also I do more of medication management. And then, of course, we have lots of technology that we utilize now. And so teaching people how to use that technology and then interpret it and manage.
Urology is a surgical specialty of the urinary tract. We manage a lot of kidney disorders, bladder, prostate, and other male genital disorders. I'm Dr. Andrew Dreslin. I'm a urologist at Gifford. One disorder we see in men, particularly as we age, is prostate cancer. It often has no symptoms until it's very advanced, but it can be detected at early stages with screening methods. That's typically a blood test called a PSA. Overall, we recommend starting that once a year at the age of 55 until the age of 70. Prostate cancer, when identified early, is very treatable with different types of strategies, but it's hard to know how to manage something until you know it's there. So I encourage everyone, particularly men at the age of 55 to 70, to have their PSA screening.
I think it's also important to when you're educating people on diabetes is to tell people what is diabetes. And I think a lot of people by now know that, in the body, your body produces insulin from the pancreas to break down blood sugar so that it can be used for energy. And you don't want too much blood sugar, obviously, in your bloodstream, but some people, they don't produce enough or not any insulin. And that's why they have to have injections of insulin to counterbalance that. So talk about, when you do have that, too much blood sugar in your bloodstream, what can that lead to?
Yeah, so there's lots of complications that can happen from high blood sugar or hyperglycemia, we call it. It can be irritating and cause damage to big blood vessels, like for the heart and brain, and then small blood vessels to the feet and kidneys and eyes and things like that. So we call them macro and microvascular complications. So big blood vessel and small blood vessel problems. And so a lot of our goal is to try to control blood sugars as well as possible so we avoid complications. The other thing I wanted to, I guess, just speak to a little bit is the difference between type 1 diabetes and type 2 diabetes. So in type 1 diabetes, it used to be thought of as juvenile or, more just children were diagnosed with type 1 diabetes, but that's changed a lot in more recent years. And so you can get type 1 diabetes really at any age. And it's more, it still is more in younger people, but it's not exclusively in younger people. The same is true where type 2 diabetes can happen in children. So it's not just the age that defines the diagnosis. So type 1 diabetes is what we think of as an autoimmune condition where the body attacks itself and it happens to attack the pancreas. And the pancreas beta cells, which are the ones that produce insulin, are affected and they basically don't work anymore at all. Sometimes it's a gradual destruction of the pancreas where it kind of happens slowly over time, and other times it's very quick and it's total. And so classically in type 1 diabetes, it's quick and sudden, and then people need insulin by an injection or by an insulin pump in order to survive. So they don't survive a long time if you weren't to have an injection of insulin. So that's type 1 diabetes. Approximately 5 to 10% of the population overall in the United States has type 1 diabetes. And then type 2, so again, 90 to 95% of the population. And I just looked quickly online on the American Diabetes Association, and they estimated about 37 million people in the United States, so large numbers, right? And they, and again, 90+% have type 2. Type 2 diabetes is what we oftentimes think of as a problem first of insulin resistance. So I always tell people that there's locks on the doors of the cells where insulin is a key that unlocks the door and it allows sugar to go into the cell, for the muscle cells, brain cells, kind of all over, right? And when you have insulin resistance, there's more locks on the doors of the cells. So I always say there's padlocks, deadbolts, there's all these extra locks and subsequently extra keys that are required. So the pancreas will make extra keys and it will work over time and kind of accommodate for quite a while with type 2 diabetes, and until it just really can't anymore. And so then that's where it's this much more gradual, kind of insidious onset in the background of higher blood sugars that eventually then lead to the full diagnosis of diabetes.
So just to say, when we're talking about differences with type 1 and type 2, now type 1, that you have type 1 diabetes, that's it, right? Type 2, if you do get diagnosed with it, that's something that you can fix, that can be reversed, correct?
Correct. So type 1 diabetes does not go away. There are some experimental still treatments. There are some, there is transplantation and there's islet cell transplants that they're doing at some of the big research centers and things like that. But by and large, type 1 is right now, forever. And then type 2, the way that people refer to it is sometimes a little bit different, but I sometimes will say that type 2 diabetes can go into remission. So if someone changes their lifestyle, or they maybe lose some weight, or they start exercising a lot, just different things, sometimes with medications in combination. In bariatric surgery, that's another example, where you can have no signs of diabetes any longer, of type 2 diabetes any longer, and then it will be in remission. However, it can return if people's lifestyle does not continue to be in that same vein that they've made those changes, but yes, it can be.
So let's talk a little bit about getting type 1 and type 2 diabetes. I imagine that from what you've been saying and from what I've read, type 1 is more genetic family history, where type 2 is more maybe diet and exercise related, maybe some genetics in there.
With type 1, there is genetics involved, but the biggest piece is not necessarily. So type 2 diabetes runs in families. It does. So if you have a first degree relative with type 2 diabetes, you're at higher risk of having type 2 diabetes yourself. In type 1 diabetes, they are doing things like twin studies and some other genetic studies, as far as looking for if people have autoantibodies and looking at the progression of if they develop type 1 diabetes. But for the vast majority, they sort of go on with their lives, and then all of a sudden they have symptoms of, like, they're really thirsty and they're peeing all the time, and they're getting up multiple times in the night to go to the bathroom, and they've lost weight maybe, and they it's pretty dramatic and pretty obvious, right? But with type 2 diabetes, again, it can happen more gradually, and sometimes people don't have those same kind of really obvious symptoms. Some people do, but other people do not. And so risk factors can be, again, first degree relative, age. As we get older than 35, we all become more at risk. Carrying extra weight. So if you have a BMI of higher than 25, so if you're overweight or have obesity where your BMI is over 30, those are risk factors. Also, having cardiovascular issues like hypertension, like high blood pressure or high cholesterol, those can be risk factors. Women who have had gestational diabetes, or women who have PCOS, polycystic ovarian syndrome. Certain ethnicities, Native American, Asian, Latino, there's lots of risk factors. There's actually a nice risk calculator on the American Diabetes Association website, so diabetes.org, where you can just answer, I think it's 4 or 5 questions, and it gives you a score of what your risk is. And if it's higher than 5, they suggest that you get screened for diabetes.
I really enjoy relationship building with patients. I think it's important that I have an understanding with the patients that I'm working with about what their priorities are, so that I'm making sure that they get the best health care that they can get and that I'm meeting their needs. I'm Bridget Meehan Brees. I'm a nurse practitioner, and I'm the new provider at Gifford's Rochester Health Center. I'm really excited to be here in the Rochester Clinic because I really like working in rural communities. My background as a nurse included working in inpatient care and in the emergency department. And while I was there, I really found that I wanted to help prevent people from being hospitalized. And so when I had the opportunity, I pursued more education to be a nurse practitioner so I could work in primary care. For the last few years, I've been in Springfield Hospital working in acute care, and I've also spent some time working at the VA in their primary care and geriatrics department. In addition to being interested in relationship building, I also like to be really open in my approach with patients and try to be a good listener. I really find that as a provider, it's important that I'm dedicated, and I take a lot of responsibility in the fact that I'm taking care of the community. We're currently accepting new patients. To make an appointment, call the Rochester Clinic at 802-767-3704.
So how do you diagnose type 2 diabetes, and maybe even type 1 for that matter? I know, just from family history, my sister is a type 1 diabetic, and so she was going to the bathroom a lot.
Mhm.
And that was something that tipped off after, going to the doctor and taking a urine test and seeing ketones in her urine. Next thing you know, she's off to the hospital.
Yes.
So talk about the diagnosis.
Exactly. And you're right. And I kind of alluded to that a little bit earlier, but oftentimes with people with type 1 diabetes, it's much more kind of like this. They're aware, they have these symptoms. It's something that's obviously not going well, going right. And so they go to their provider and they find that, that their blood sugar is really high and whatnot. With people with type 2 diabetes, they may not have symptoms. It may be just going on gradually in the background where their blood sugar is higher. And how, again, I mentioned where we were encouraging people to go on the Diabetes Association risk factors score, basically, for a lack of a better way of saying it, is to identify if they were at risk. So if you find that yourself, feel like you may be at higher risk and you want to go in and, talk with your provider about it, what we often do as providers is we get blood tests and we get a fasting blood sugar. That's one way to diagnose diabetes, and higher than 126 milligrams per deciliter is the diagnosis of diabetes, or the fasting blood sugar. And then a hemoglobin A1C, which is a blood test again, which is basically an average blood glucose over the past 3 months or so. And when that comes back as higher than 6.5%, that is a diagnosis of diabetes.
It's interesting how different they both are, but how similar the both types are in certain ways.
So the risk of complications is there for both type 1 diabetes and type 2 diabetes because they result from high blood sugars. Sometimes the rate at which people can get complications changes. So because there is an assumption that there's been some level of high blood glucose going on in the background when someone is first diagnosed with type 2 diabetes, we start to look for complications early on. And then when someone has type 1 diabetes, it's more in that 10 years after diagnosis that they can be developing complications if their hemoglobin A1C and their glucose has been elevated. Of course, that's not always the case, but when you're thinking about kind of typical.
And when we're talking about complications, we often hear a lot about foot care. Fortunately, we have a great podiatry team here at Gifford who specializes in foot care for people with diabetes. Katie, can you kind of tell us why we hear so much about issues with feet when it relates to diabetes complications?
We do have some great podiatrists in several locations here. I'm thankful for them. So when there's damage from high blood sugars, they can involve the small blood vessels of the body and the nerves. And so neuropathy, peripheral neuropathy, is damage to the nerves of a lot of times lower extremities, the feet. And so when people have complications from diabetes, such as neuropathy, they don't have the same sensation in their feet. And they also maybe don't have the same circulation in their feet. And so the wound healing can be impacted. So if somebody doesn't feel their feet very well and they accidentally step on something, or they get an injury that seems pretty benign, but then they don't really notice it, and then time goes on and it can then lead to an infection, and then a wound, sometimes lots of really bad problems. And so that's where we want to avoid that, right? And so we want people to have podiatry in place as part of their team, so they're getting their feet evaluated by a professional regularly. And then if there were to be an issue for skin breakdown or an ulcer or whatnot, they would be able to get into their provider and get early treatment, so they wouldn't have, as many long-term issues, hopefully.
I want to talk a little bit, just for briefly, about low blood sugar. And I know that that's more common with type 1 diabetics, but I've had a couple of instances. My sister, I was at an event once where someone had a low blood sugar reaction. And it's just a scary thing to see. We were at a golf tournament and there was somebody taking pictures there, and all of a sudden they just froze up and they just started moving like in slow motion. And they had this like smile on their face. It was really odd. And right away, I knew, though, that they were having a low blood sugar reaction. And so, and only I knew, other people were there and they knew, but I recognized that from when I was growing up with my sister. And when my sister had a couple of those instances, what my parents would do is take icing, cake icing, and rub it inside of her gums, and so it would get absorbed, and then she would kind of snap out of it. So I know it's not something that you commonly see, but if it is something you do see, then somebody acting weird in that way, it might be what's going on.
Yes. So for sure, we see low blood sugars a lot, or hypoglycemia. You're right. In people with type 1 diabetes, it happens very commonly. In people with type 2 diabetes who are treated with insulin, it can happen as well. Some of the oral medications too. But you're right. People can seem impaired. They can seem, really out of it. It's really important for anybody with diabetes to wear a medical alert bracelet or necklace, or some way of identifying that they have diabetes and they're on insulin. And so then a first responder or somebody could know, okay, they need glucose, they need fast sugar. And then in that circumstance we were talking about, where your parents would use the icing for cake icing, that's pretty much just sugar, right? And so, and it's almost liquid, or close enough where when you put it into your mouth, it quickly absorbs. And so we do things like that. We try to teach our patients to recognize the signs of what a low blood sugar might look like, where they might feel shaky and sweaty, and they might feel out of it and just like they can't really think straight. By definition, it's a blood glucose under 70, and a severe low blood sugar or hypoglycemic event is under 55. And so we treat it with a fast source of sugar. So glucose tablets, they make these little like wafer type of tablets that oftentimes people will carry, or like you mentioned, a gel, or a little, some orange juice, 4 ounces of juice, something like that. And it doesn't take long, about 10 minutes maybe, and somebody's kind of back to their typical baseline. But it is scary. And that's where it's good for not only the person with diabetes to know what's going on and how to treat it, but also their loved ones and family members that might be around them.
So my sister was diagnosed when she was 8. She's going to be mad at me if I tell what her age is right now. But for the math, it was about 32 years ago that she was diagnosed.
Yeah.
And back then, it was so different. I mean, all of her food had to be measured before eating. Obviously, taking insulin twice a day with a syringe. she would carry around with her animal crackers, orange juice, a little tube of frosting just in case. And she did have her alert bracelet, and she would test constantly. And now, 30 so years later, you see such the technology that's come along to help in caring for not just the type 1, but type 2 as well. Do you think that there's one big breakthrough over the last 30 years that's just really changed the way diabetics, people with diabetes, can care for themselves?
Yeah. Oh, thankfully we have come a long way with diabetes. Yes. I would say probably the biggest impact for the largest population is the continuous glucose monitors. I don't know if your sister has one, but there's quite a few different products now that are available that continuously monitor someone's glucose. And it's so nice, because even if someone does test their blood sugar frequently, there's a lot of information that we miss and in between those finger sticks. And so this gives us the ability to look at trends and look at direction in which the blood glucose or the glucose is going. It's not actually measuring blood glucose, but what direction it's going in. And again, these continuous glucose monitors are integrated with several different insulin pumps now, and that has just made an amazing difference as well, as far as being able to have some automated delivery of insulin. It's not completely, we haven't, it's not the artificial pancreas yet, but we're getting closer, and it's awesome. And it just feels like because it's a heavy lift for a lot of people. It's a lot to live with every day, day in and out, throughout. And there's just a lot, it can be a big burden. And so if we can have different technology that can make it easier to live with and make less, pain by physically having to poke your blood sugar, in your fingers 4, 5, 6, however many times per day. You wouldn't have to do that so many times per day with a continuous glucose monitor. That's wonderful. And so I think that's probably one of the biggest impact in the past probably decade. Again, though, with type 2 diabetes, we have a lot of new medications that are really beneficial, and not only just in treating blood glucose, but also in treating, some can help with people to lose some weight, some can help with decreasing risk of death from cardiovascular events such as stroke and heart attack and whatnot. So it's exciting that we have good medications, good technology, that we're going in the right direction.
I remember her getting her blood test and she wasn't feeling good, or, she was feeling like she was having a low blood sugar moment, and she would test, and you have to wait like 45 seconds and they would count down, and she would just count down, and you're like, now it's just instant. It's instantaneous. And it's just to see that progress. It's pretty cool. And when you have that connection, to see that happen over the years, you remember all of the, just all the syringes and all the blood tests. So
for sure,
it's really come a long way.
Well, now you can even watch your glucose on your Apple Watch or your smartwatch from your CGM can send the data there. So, I mean, we're definitely making progress.
And it's cool in the sense that what you were talking about is, if you're into like stats, and if you're into it's really, you're charting, you're monitoring, you're looking for patterns. It's really watching. I've seen you and Jennifer before kind of analyze going through someone's glucose monitor and kind of seeing. It's really fascinating how you can look at the history and then put a plan together going forward, or plan ahead if your lifestyle is going to change a little bit. If you're going on a trip, if you're going for a long adventure run that you don't normally do, you can look at the numbers and plan ahead for stuff like that.
Yes, and our goal is to involve our patients in that. Like, we're all a team, right? And so we have to we look at that data together. Not only do we sort of make some interpretations, but we also look to our patients to say, okay, what do you see, and what are issues that you're feeling like you're dealing with? And we try to kind of match those up, and then, like you said, prepare for some, activity or different foods, and really kind of make a plan. I think it's just it's funny. I don't know how we practiced without continuous glucose monitoring in the past. Now I'm so reliant on it because it's just so helpful. I think it should be available for everybody with the diagnosis, and we're certainly trying to advocate for that. But
And I think that's a big part of what you and Jennifer do, like you said, and teaching how this equipment works and how you can use the equipment to your benefit, and how you can let it work for you.
It's been a really good team approach that we have within the podiatry department, and we've all worked well together, so it's a good fit.
Dr. Bjork, Dr. Andreasen, and myself all practice very similar ways in podiatry. We do full spectrum foot and ankle surgery when necessary. If it involves the foot and ankle and it comes to the door, we can take care of it.
You don't get a lot of specialists in rural healthcare, and so being able to bring podiatry to help any people who like to ski or the farmer and they have a foot issue is very big, because then they don't have to travel hours upon hours upon hours to get to a foot doctor or an orthopedic doctor to look at their ailments.
We have Dr. Bjork in the Berlin office and down in the Randolph hospital. We have Dr. Andreasen down in the Sharon office and also up in Randolph, and myself at Gifford in Randolph and down in the Sharon office.
That's worked really well just to serve the different regions within Vermont and being able to offer the podiatry care.
We're very excited to have Dr. Andreasen join us. He spent 3 years in Binghamton, New York, doing full spectrum residency and foot and ankle surgery. So he brings a new set of skills that we're excited to start using here at Gifford.
Stephen Andreasen, he's really fit in well. It's been nice being able to have others that can touch base with if there's something unique that I haven't seen or somebody else hasn't seen.
I enjoy working with both Dr. Benoit and Dr. Bjork. They are a great resource for me. One of the biggest things is that I can bounce ideas off of them, and they can bounce ideas off of me.
If you are dealing with any problems with your foot, your ankle, lower leg, it certainly is something that we want to address.
The longer these things continue on, the worse sometimes they can get. So we'd rather see something much sooner than later.
When should you really go see somebody? When this is happening, when this is happening, when this is happening?
so we do recommend that someone would see a diabetes educator when they were first diagnosed with diabetes, just to spend some time to learn more about the diagnosis and to talk about their own individual lifestyle, and if there's areas that might have aspects that could be improved or tweaked. And again, I think sometimes people think that they have to overhaul their whole life if they've been diagnosed with type 2 diabetes, and that's really not the case per se. Sometimes just small changes, they really can add up. And so hopefully coming to see a diabetes educator and talking about that could feel more attainable than sometimes feeling like, oh gosh, I have to change everything that I'm eating or everything that I'm doing. So certainly at diagnosis. And then if you're not at target, if things are not, if I mentioned that the diagnosis of diabetes is made if the hemoglobin A1C is greater than 6.5. The goal for most people with diabetes, according to the American Diabetes Association guidelines, is an A1C of less than 7%. And so if you're finding that your hemoglobin A1C is not at goal and you want some more education, that's a good time to come and see a diabetes educator. And then certainly also for technology, for people with type 1 diabetes, they really should always be connected with either a diabetes clinic or an endocrinologist, just for a little bit more support. And then again, if you're utilizing continuous glucose monitoring and pumps, it's probably best to have the support of diabetes clinic. And we try to be flexible with people as far as the follow-up. Some people need more short and close follow-up, and some people really just want to be able to kind of check in once a year or maybe twice a year, and they follow up regularly with their PCP, and they don't need to see us all the time per se. So we try to make an individual plan with our patients.
And we have a couple of diabetes clinics here at Gifford, one in Randolph at our Kingwood Health Center, and we work also in Berlin at the primary care clinic.
Correct. Yes. So both Jennifer and myself work out of those two locations that you mentioned, Kingwood and Berlin Primary Care. Jennifer also does travel to Chelsea Health Center and also to Bethel Health Center, some to help to provide some diabetes education in some of those clinics as well.
And we have all of that information on our website, giffordhealthcare.org. You can click under the locations tab. You can click under the services tab, and you can find everything that we provide when it comes to diabetes care. Before we go, we're going to talk about a big event coming here to Gifford on December 1st. Tell me all about it.
It's going to be exciting. We're going to have several speakers, myself, Jennifer Stratton, Dr. Bjork, another dietitian, Annie. We're going to be all presenting kind of a short topic about kind of all things diabetes, a little bit more about continuous glucose monitoring, how to take care of your feet, etc. So we're excited. We hope that lots of people come and join us and learn a lot.
And if you are not from the Randolph, Vermont or Central Vermont area, you can't make it, we will have clips available on our website and our YouTube page as well. So if you're listening somewhere else and you're still interested in learning more about diabetes and diabetes care, we've got you covered. Again, giffordhealthcare.org. Our YouTube page, if you do a search for Gifford Healthcare, you will find all of our videos there. Again, if you're watching this interview on YouTube, give us a like, hit the notification bell, the subscribe button, and that way you will always know when we are putting new videos up on our YouTube page. And again, we're on Spotify, Google, Amazon, Apple Podcasts as well. Go over there, rate this podcast, leave a comment. And Katie, John, once again, thank you for joining us. And it's a very important month, Diabetes Awareness Month. Let's hope that some people out there are listening to this podcast and get in there to see their primary care providers, and then maybe go to a diabetes clinic and find out more information on how they can better live their lives with either type 1 or type 2 diabetes.
Yes, thank you, Scott.
And we'll see you next time on the Gifford Provider Podcast.